All right, so all of us in this room, we know what lymphedema is. But what we don't know is what lymphedema means for patients. So this is something I started to look at, and I asked patients, actually many patients, about how lymphedema impacts their lives. And I put here some quotes. The one which really surprised me the most, I fear lymphedema more than recurrence. And not only one patient told me that, it's many patients. Another one, it has ruined my life. I would almost rather I had died. Now you have a patient who survived breast cancer and would tell you, I would rather have a local recurrence or the cancer coming back rather than having lymphedema. This is how important lymphedema is for the patient. The other thing is that it doesn't affect only the patient, it affects also the whole family. It strangles the mobility and quality of life from my wife and therefore from me. So lymphedema is a crisis of quality of life. Why is that? Because it is obvious to the public. I mean, you can have a lot of complication from chemotherapy, from radiation, from surgery. Everything is hidden. Neuropathy is hidden. Alopecia is hidden. But when you have an arm like that, it is not hidden. It's a constant reminder of the patient that she had breast cancer. And when you look at every impact here is like documented with data. This is not just like putting a list. Sadness, anger, depression, and anxiety. So basically, your life is upside down. And those patients live for a long time when they are cured from their breast cancer. So why is that? Because for many decades, when we dealt with lymphedema, we used impairment-based model, which means that, let me see the problem. You have a swollen arm, okay. Go to see the physical therapy and goodbye, and that's the end of it. And it's always really advanced like that. And we don't take really charge of these complications. What I would like to see, and we started to practice in my institution and few other institutions in the US, we'd like to see a screening-based model, which means that we screen for lymphedema and we catch it very early. We catch it before we see it. And when you look at mammograms, when mammograms detect DCIS before you feel it, before you see it, you have a very high cure rate. The same thing happened here. If we only rely on seeing the arm swollen, it's already maybe 15% relative volume change. But if we can detect lymphedema before we see it, but with some tools, and then we intervene at that time, there is a hope that this can be cured with treatment. Once the lymphedema reaches that level, there is no cure, and we need to know that. And in general, we see 20%, maybe 30% of patients who present with lymphedema. This has been high many decades ago, but with the introduction of sentinel node, it went down. But of course, it depends on where you live and where you work. In developing countries, I would think it will be much higher than that. So it's really rely on what type of surgery is being done. Let's go down to the basics. What is the optimal technique to measure lymphedema? So mostly it's volumetric. The most simple one is a tape, and that's the cheapest one. And anywhere you could do that. You don't need to take the circumferences at 4 centimeters. It takes longer time to do it. It could be more simple, and you could take circumference at only 5 points, and then you transform all these circumferences into volume by using the truncated cones formula, which can be found online without any problem. So that's the most simple thing. Whether you do 5 points or 15 points, there is no difference. You are as good with 5 points, so this can be done rather quickly. So that's with the tape. There are tools like Pyrometer. It uses an infrared red, and it brings really very accurate volume. It shows up on your screen, and it can calculate it. And there is something new, it's called LymphoTech. It's a camera which can really look or calculate the volume of your arm quickly. This water displacement has been used in the past. It's just very unhygienic, and you cannot screen with it. And there is a new technology that the bioimpedance coming mostly from Australia, and it reflects the ability of an electrical current to pass through the limb. We are still testing that. Some people use it to diagnose lymphedema. We are not. So this is a different method to calculate to measure lymphedema. Now the very important question, is it necessary to have a baseline measurement? It is very necessary to have a baseline measurement. Baseline means before surgery, and that's why you cannot build a lymphedema screening without the surgeon. If the surgeon is not into it and you miss the baseline, you cannot screen. I will tell you why. Because we looked at 1,000 patients, and we had 35,000 volume measurements, and we found there is an asymmetry between right and left, just without any surgery, of up till 10% increase in volume in 3% of the patient. Now, the definition of lymphedema is 10% relative volume increase. If you miss this information, you will overdiagnose or underdiagnose a lot of patients. So a patient would not have lymphedema, and if you don't have this information, you measure after surgery, you found that one arm is larger than the other, you will label her as having lymphedema and will never respond to any treatment because she does not have lymphedema. It is very important to have a baseline. And then more than 5% we found in 28% of the patients. Now after that, I asked my team, if you miss the baseline, what will happen? Like, what is the level of uncertainty? And I was surprised to see the answer. So in this study, we took 1,000 patients who had all of them baseline. And we had also a post-operative measurements. We called it immediate pseudo-baseline and beyond 3 months, assuming that after surgery, you have some swelling due to surgery. And we called it also delayed pseudo a baseline. And we found if you don't have the real baseline, you will overdiagnose or underdiagnose 40 to 60% of the patients. So if you miss the baseline, you cannot really measure the patient after surgery. You will misdiagnose her. So that's how important the baseline is. It's not only our group who found this. There is a British group, very respected group, who studied 1,100 patients. At baseline, they found 8% of the patients, they had one arm larger than the other by more than 200 milliliter. A lot of people consider the definition of lymphedema as 200 milliliter difference. It's also at baseline, the same group, they found that symptoms of swelling and heaviness were found in 8% of the patients. A lot of people diagnose lymphedema by the symptoms, and specifically the symptoms of swelling and heaviness. If you don't have a baseline to know that the patient didn't have it, you will misdiagnose lymphedema. Our field of lymphedema has a lot of misdiagnosis, and this is very important. How do we quantify lymphedema? So we generated an equation, relative volume change, which is basically based on the baseline measurements. A is affected arm, U is unaffected arm, 1 is the baseline. And this is online and has been validated, and several institutions are using it beside ours. So this is simple. You take the baseline volumes and the volume of the day in your follow-up, and then you plug them in this relative volume change formula, and you get the percentage increase in volume. How do we define lymphedema? And this is a big problem in this field. If you look at all the literature, you will find many, many definitions. So there is no universal standard definition. This means like you have 20 people sitting in the same room trying to talk together about one issue, and everyone is speaking different language. So you have the absolute, three, absolute circumference, absolute volume, absolute difference, percentage, and I will tell you where using absolute is flatly wrong. We use the relative volume change, more than 10%. That's mostly the universal agreement in a way to define lymphedema, and there is LD score, which comes from the bioimpedance. Simone Settlement did a meta-analysis and selected the best studies in the literature. All of them were prospective. Half of them were randomized clinical trials, and started to look at them. Almost 15,000 patients. What she found is that the method of measurements was completely different from one to the other. Subjective, arm circumference, not reported even, arm volume. So each one has a different endpoint. I mean, it's lymphedema. If we want to have an endpoint of lymphedema, everybody is measuring it differently, and these are not interchangeable. And the other thing, the lymphedema definition, not reported, self-reported, MD assessment, more than 2 centimeter tape circumference. I think the next step in the field of lymphedema, let's just sit down together and define lymphedema with something which could be acceptable. Why 2 centimeter difference or 200 ml difference is not right? And we have been using the 2 centimeter circumference difference for decades. And I remember when I was resident, I used to have the tape and measure. And I didn't know what does this mean. But until now, this is being used. If you take a 200 ml difference, you take a small arm like that, and this arm had an increase in volume by 180. 180 is not lymphedema, because lymphedema, you have to cross the 200 ml. But with 180, you have 15% increase in volume. So you underdiagnose this patient. You take the opposite, this large arm, 220 ml is lymphedema. What this represents 3.7% relative increase in volume. This is not diagnosed as lymphedema. So you will overdiagnose this patient here. And when you plot this, if you have just an absolute difference, it will represent 15% in some arms and 3% in other arms. So absolute volume change correlates with the arm volume, the patient weight, the body mass index. But what you need is an endpoint which is completely independent from how the patient looks or how the original arm volume is. And that's why using 2 centimeter circumference is wrong and should not be used. So what we are trying to do is a prospective screening program in order to identify patients at a very early stage with lymphedema, before you see it with your own eyes. 7%, not yet lymphedema, but it's close, and you can't see anything. 11%, you could see just a little, but likely curable with conservative treatment, and once it reaches that level or more, that's it. It's going to be just maintenance and palliative. In order to establish a lymphedema screening program, you need to build a team. You cannot do it on your own. You could be a surgeon, you could be a radiation oncologist, a medical oncologist. You could be anything, but you need everybody together. Surgeons are extremely important. And then we usually collect patients-reported outcome, like surveys from the patient. And if you look at the cost, and forget about the absolute numbers here, but in general, and this is just one paper, that when you screen, the cost is much less than when you have a patient with already lymphedema coming back and forth with cellulitis, admission. This will, over time, over the years, will increase the cost. And the important thing is that screening for lymphedema is recommended as a standard of treatment by 5 different organizations. The NCCN organization is very important in recommending the standard of treatment, also the American Society for Breast Surgery. So let me summarize. If you want to plan for a lymphedema screening program, you want to start early, you have to use volumetric method. You need a baseline measurement. You could use a relative volume change formula. The definition of lymphedema is relative volume change more than 10%, and you could integrate symptoms from the survey. So that's the basics for lymphedema. Now, what are the risk factors for lymphedema? And I identified 6. We're going to take one by one. The most important risk factor for lymphedema is very simply axillary lymph node dissection. And you could see here in a study from our group, on 1,800 patients followed with baseline relative volume changes used, and we defined it as more than 10%. That's the routine in my group. The risk of lymphedema with lymph node dissection was 25% at 5 years, with the sentinel node is actually 8% or 5 to 8%. So you do sentinel node, you bring your risk of lymphedema very much down. You continue to do lymph node dissection, your risk of lymphedema is clearly much higher. And there are also other groups which goes in the same direction. What about radiation? And radiation has this perception, radiation can cause lymphedema. So let's look at that. First, there is a difference between just radiation and actually regional lymph node radiation. So this is a study on 1,500 patients from our groups with the same screening program. And what we found is that if you treat only the breast or the chest wall, it's close to no radiation at all. And actually, radiation of the breast does not impact the risk of lymphedema. The only radiation which impacts the risk is basically regional lymph node radiation, either supraclav or axilla or both. And that's the risk. It goes down, look how far compared to no radiation. So very important to know that it's a regional lymph node radiation which increases the risk of lymphedema. And this is the multivariate analysis. Now, the other thing which I really want to underline, what is the contribution of radiation compared to the contribution of lymph node dissection to the risk of lymphedema? So when we compared in the same previous study, the risk of lymphedema with lymph node dissection alone without radiation versus the risk of lymph node dissection plus regional lymph node radiation, there was an increased risk, but the increase was only 5%. So we went up from 25 to 30%. So the contribution from radiation is actually very little. It's not as big as we thought from the old publication. And when you look at the risk from the sentinel node, it goes up from 8% into, when you add regional lymph node radiation, into 11%. The risk is small. So what we learned from here, that the contribution of radiation to the risk of lymphedema is little. So if you want to reduce your risk of lymphedema, I don't think that manipulated the fractionation of radiation will bring any benefit. It's mostly the strategy should go towards surgery. And something very important, a question we raised, when does lymphedema happen? So we looked at 2,000 patients followed with prospective measurements. When you look at lymph node dissection, the risk is rather early. It's within 6 to 12 months. And then when you add radiation on top of the lymph node dissection, the risk peak at 18 to 24 months. So the patient's still at risk on at least 3 years. So if you have a trial that you want to follow patients with an endpoint of lymphedema, following the patient for only 1 year will make no sense, because lymphedema can happen after 3 years or after 4 years. And then it goes down at 5 years. But something very important to know, that lymphedema risk is for life, and you need to know that. But what I see, the risk from the original treatment maybe end at 5 years. After that, the lymphedema, when it happened, there is something which triggers it. Cellulitis can trigger lymphedema after 10 years or 15 years. I have seen that. Trauma, or an operation, or the arm is broken and then you do an operation, or I remember a patient who had leak from her implant, just removing the implant triggered lymphedema after 15 years. So you've got to be careful with the patient and informing them about those risks. So in conclusion here, the regional lymph node radiation increases the risk of lymphedema, but the main contribution remains with axillary surgery. Therefore, omission of lymph node dissection, if possible, should be the key prevention strategy. Now, what about the third factor, BMI and weight fluctuation? It is very universally known that high BMI is a risk for lymphedema. And this is something that when you look at every paper, it's there. So we have to be careful. And the BMI could be more than 30. Between 25 and 30 is not real, but it's more than 30. And this is the multivariate analysis. And it's only the BMI at diagnosis. Because when we've done a study, we followed the BMI for 5 years. And just with a common sense, we said if the patient goes on a diet and reduces her weight, maybe the risk of lymphedema will go down. And to our surprise and disappointment, it did not happen. It's actually whether you gain weight or you lose weight after diagnosis, your risk of lymphedema will stay the same. And we are not the only one who found this conclusion. What about chemotherapy? Does chemotherapy increase the risk of lymphedema? Well, it's not really clear. So you will have studies which found association between chemotherapy and lymphedema, and those are the references. And you have other studies which did not find any association. So we really don't know. But Taxol has this sort of perception, or the taxanes, because water retention, and some studies will tell you Taxol increase the risk of lymphedema. Us, in our database, we analyzed 2,000 patients, and we did not find that Taxol increased the risk of lymphedema. What about cellulitis and seroma? Cellulitis and seroma increase the risk of lymphedema. And this is a study. We followed 632 patients. The multivariate analysis showed that lymph node dissection and BMI increase the risk of lymphedema, and we saw also cellulitis. And you have to be careful. Cellulitis is really bad, and you have to attack it right away very aggressively, because I have seen just the arm really increase in volume rather quickly when you have cellulitis. What about subclinical lymphedema? What is subclinical lymphedema? It's basically not really lymphedema, but not normal. So it's a small swelling. And we define this swelling as 5 to 10%. So if lymphedema is 10% or more, the patient can have mild swelling between 5 and less than 10%. So we wanted to know, if we catch this little swelling, can we prevent it from progressing? So we looked at a study with 1,700 patients. And we found that women who had lymph node dissection, 40% of them moved into subclinical swelling. So we continued to watch those patients, and we found that some of these subclinical swelling regress and others progress. 40% of them progressed into full-blown lymphedema. And we are trying to study if we intervene with just sleeve for a month or two, at this point, can we prevent the progression of this? So the whole philosophy is, don't wait until you see it. Detect it as early as possible and try to intervene at that time. So here, I would say that patients who experience subclinical lymphedema after axillary surgery are more likely to progress to lymphedema, but mostly the patients with lymph node dissection and early intervention should be encouraged. So how do we avoid or decrease the risk of lymphedema? I think the best way is avoid lymph node dissection. I mean, you cannot do lymph node dissection for negative lymph nodes. It's almost unethical now. And I would rather not do any surgery at all to the axilla than do lymph node dissection when the axilla is negative. Can we avoid doing lymph node dissection for positive lymph nodes? So we all know the Z11 and the Amaros showed very clearly that you don't need to do lymph node dissection if you have 1 or 2 positive lymph nodes. And you could substitute this lymph node dissection by lymph node radiation. We looked at this in our database on the 1,800 patients. If you do lymph node dissection plus regional radiation, your risk is 30%. If you do sentinel node plus regional lymph node radiation, is 10%. So by avoiding lymph node dissection, you reduce the risk from 30 to 10%. And your risk of axillary recurrence is the same. So if you do lymph node dissection or you put radiation there, you will have the same risk of axillary recurrence, which is very low. And this really mimics the data from the Amaros study. So how do we treat lymphedema? So there are a few different approaches. Prevention, conservative and surgical. There is conservative management and surgical management. So very quickly, prevention regarding the conservative approach to prevention. And this is a study which came from the Tata Hospital in India and was in collaboration with a group from Australia, published very recently. 300 patients, all of them had lymph node dissection, were randomized into compression. You just give compression sleeve right away after surgery versus control group, which received the usual care. And they defined lymphedema as a relative arm volume of more than 10%, but also they had a different definition using bioimpedance. They measured and followed their patient for 1 year. And they measured at 1 month, 6 months, and 1 year. And they found that, in fact, prevention sleeve reduced the risk of lymphedema from 25% to 14%. So this study was positive. And they found that the arm swelling developed later in the compression group. So my concern is that it just delayed and did not really prevent, because they had only 1 year of follow-up, and I showed you that lymphedema can show up almost after 3 years. So to look at this study, and I love this study because I'm trying to test this hypothesis in the US, not enough measurements after surgery. When lymphedema was diagnosed, was not confirmed with clinical examination. There is also lack of adherence data. What you need to know is that when you ask the patient, you need to put the sleeve for a month, 12 hours a day. How do you know that the patient does that? We have a lot of compliance issue with that. And the way how they did it, they told the patient, you need to put the sleeve all the way until 3 months beyond your last treatment, with the exception of hormonal therapy. So you will have some patients who did not receive, for instance, chemotherapy or radiation. The patient will have the sleeve for 3 months. And the patient who had chemotherapy and radiation, she will have the sleeve for maybe 10 months or 12 months. So the length of using the sleeve is very variable within the tested arm. The other thing which really, so besides the follow-up was too short, we found that the patients, 40% of the patients had negative lymph node dissection. So this is something is usually not done in many places. You don't do lymph node dissection for patients with negative lymph nodes. So that's the way how you could prevent developing lymphedema conservatively by using a sleeve. The other thing is there are some surgical maneuvering, a maneuver called axillary reverse mapping. So basically, when you do sentinel node, you inject the dye in the breast, and then it goes to the sentinel node. So here, they inject a dye in the upper inner arm, and then the dye will move into a sentinel node for the drainage of the lymph from the arm. And sometimes the crossover rate can vary from 0 to 28%. So it is the same lymph node which really drains the arm and drain the tumor. So what they do, they avoid removing this lymph node. Or if they have to remove it because it is the same sentinel node identified from the breast, they try to recanalize or redo different maneuvering to avoid removing or interrupting the flow. Evidence suggests that sparing non-crossover arm node can be safely implemented, and there is a randomized trial, and this is very important. It's not published yet. It's accrued, and it's going to be published in 1 year. The other surgery is called LYMPHA, Lymphatic-Venous Anastomosis. So the patient undergo lymph node dissection, and then when this is done, the microvascular surgeon comes in and then start to look at where is the disruption through some imaging, and then they start to identify the lymphatics and try to connect it to a branch from the axillary vein. So they call this LYMPHA. It's starting to gain some traction in the US. Many institutions, they do this to every patient with lymph node dissection. There is no randomized trial published yet. There is one coming from Memorial. It's still accruing. So we'll know at that time whether there is a benefit from it or not. There is some meta-analysis of a lot of retrospective studies suggest that the risk of lymphedema goes down from 30% to 10%, but it's not randomized yet. Now, how do you treat lymphedema conservatively? Through two phases, a reduction phase and a maintenance phase, and you have the manual lymphatic drainage and the compression 24 hours, and the same thing with exercise and skin care, which we all know. That's the standard thing, wrapping. See how painful it is, how every day the patient should do that. And this is regarding the compression option, which just you put the sleeve for a X number of days. Now, what about surgical management? Can we treat lymphedema with surgery? Well, there are three different approaches. The first one is the lympho-venous bypass. All what you need to do, so you will look at the at your lymphatic system through a ICG, like some dyes, and then you will look at where it is disrupted, and then you just recanalize to a vein. And it's rerouting lymphatic drainage pathway. Well, it doesn't take too much time in the OR, and some people do that, but what you need to know, it is not curative by any means. And every paper will tell you that. What is important that most patients will report symptom improvement. All their symptoms will improve, but they will still need to continue with sleeves. And so that's the first one. The second one is basically vascularized lymph node transfer. And some people reported that when they took the lymph node from the inguinal area, some patients developed lymphedema in the lower limb. Lymphedema in the lower limb is very nasty. So they stopped doing that, and they take the lymph node mostly from the omentum. And there are a lot of experience coming from Iowa, 1,500 patients, and again, 98% experience subjective improvement. So those surgeries just improve the symptoms. But at the end, you still need to put the sleeve. The swelling doesn't go away. The last one is basically liposuction. And it's a very simple liposuction. This is the arm before, this is the arm after. In the great majority of people who do that, the arm look really very good. The swelling goes away. But the patient will still need to put sleeve because it is not a physiologic treatment. It's just almost cosmetic treatment. So in conclusion, how can we reduce the risk of breast cancer-related lymphedema? Screening program. Get it early. It doesn't take too much. Get the breast surgeon involved with you. And then you could really help patients to spare them the risk of lymphedema. Identify the high-risk patient. The highest risk patient will be a patient with lymph node dissection and high BMI and regional lymph node radiation. So if you have a patient with those three, you've got to really follow her very closely. And as soon as there is an increase in swelling, you just put the sleeve. So the treatment is not that difficult. It's just giving the patient sleeve. And needs counseling and close observation. Avoid lymph node dissection with 1 to 2 positive sentinel node. And I'm trying to study whether can we move up from 1 to 2 into 3 or more. Like really, we want one day that nobody should have lymph node dissection at all. It seems to be a little remote, but if we go step by step, we might reach that level, because the most important factor to increase the risk of lymphedema is the lymph node dissection. Use of prophylactic sleeve to prevent lymphedema needs more studies. I'm not sold with the paper from India, but we need other group to really find out whether it works or not. I would like to acknowledge my group who generated all these data, and thank you for your attention.